Summarizing tumor lysis syndrome, TLS. Risk factors. 1. Tumor-related factors. High tumor burden, bulky disease, large tumor mass, or rapidly proliferating tumors. Tumor type, most commonly associated with hematologic malignancies, Burkitt lymphoma, acute lymphoblastic leukemia, ALL, acute myeloid leukemia, AML, with high white blood cell count, diffuse large B-cell lymphoma, DLBCL, solid tumors, rare, but possible in cases of high tumor burden or metastatic disease, e.g., small cell lung cancer, breast cancer, germ cell tumors. 2. Patient-related factors. Pretreatment elevated serum uric acid or lactate dehydrogenase, LDH, markers of high cell turnover. Pre-existing kidney disease or dehydration reduces the kidney's ability to excrete uric acid, phosphorus, and other metabolites. Oliguria or volume depletion. Aciduria promotes precipitation of uric acid in the renal tubules. 3. Treatment-related factors. Use of highly active chemotherapy, especially in patients with chemosensitive tumors. Corticosteroid monotherapy can sometimes trigger TLS before full chemotherapy begins. Radiation therapy or immunotherapy, e.g., bispecific T-cell engagers, CAR-T cells, in high-risk patients. Diagnosis. The laboratory diagnosis requires the presence of at least 2 metabolic abnormalities occurring within a 24-hour period. Phosphorus levels at or above 4.5 milligrams per deciliter, a 25% increase in potassium, or levels reaching 6 milliequivalent/L, corrected calcium at or below 7 milligrams per deciliter, and a 25% increase in uric acid, or levels reaching 8 milligrams per deciliter. The clinical diagnosis requires at least one criterion, specifically a creatinine level 1.5 times the upper limit of normal. Arrhythmia, seizure. Management. The recommended management strategies include aggressive intravenous hydration and maintaining high urine flow. It emphasizes medical management of electrolyte abnormalities and uric acid therapy using either allopurinol or rasburicase. Hemodialysis is indicated for cases of refractory hyperkalemia or symptomatic hypocalcemia. Summary: TLS as an oncologic emergency caused by the lysis of tumor cells, leading to hyperkalemia, hyperphosphatemia, hyperuricemia, and hypocalcemia. These abnormalities can result in cardiac arrhythmias, seizures, and death, and reiterates that IV hydration, allopurinol, and rasburicase are the cornerstones of prevention and management. In TLS, muscle twitching isn't just cramps, it's hypocalcemic tetany. Nurses save lives by catching potassium spikes before the QRS widens. Mr. James Keller, 28-year-old male history, newly diagnosed Burkitt lymphoma, abdominal mass, WBC 120K/L, started R-EPA chemotherapy 24 hours ago, baseline creatinine, 0.8 milligrams per deciliter. Presentation, moaning in bed, clutching abdomen. I can't pee and my heart is racing. Vitals, BP 88/50ths, HR 132, RR 28, temp 37.8 degrees Celsius, SpO2 94% RA physical. Cardiac, irregular rhythm, tall T waves on telemetry. Renal, anuria for 4 hours, flank tenderness. Neuro, twitching in hands/feet. Labs stat, potassium 6.8 milliequivalent/L. Uric acid, 18.2 milligrams per deciliter. Phosphate, 9.1 milligrams per deciliter. Calcium 6.9 milligrams per deciliter. Creatinine, 3.9 milligrams per deciliter. ECG, peak T waves, widen QRS. Diagnosis, clinical plus laboratory TLS. A patient with suspected tumor lysis syndrome, TLS, has a serum potassium level of 6.8 milliequivalent/L. An ED instant ECG shows a widened QRS complex. The patient is not yet on a continuous cardiac monitor, which is the most urgent initial nursing action. A. Administer IV calcium gluconate. B. Initiate continuous cardiac monitoring. C. Give rasburicase IVD. Obtain a CT abdomen. Answer B. Initiate continuous cardiac monitoring. This is correct. the most urgent initial action to ensure patient safety. A potassium of 6.8 milliequivalent/L with a widened QRS places the patient at imminent risk for ventricular dysrhythmias or asystole. Even though a 12-lead ECG has been obtained, it provides only a snapshot. Continuous cardiac monitoring allows the nurse to detect life-threatening rhythm changes instantaneously and to safely administer interventions, calcium, insulin, etc., with immediate feedback. This aligns with the CGMM principle of recognizing high acuity cues and taking the first essential step to prevent cardiac arrest. A little further, take action for this hypothesized priority. Immediately apply continuous cardiac monitoring. Ensure a defibrillator is at the bedside, and then rapidly administer calcium gluconate, insulin/glucose, and other hyperkalemia protocols while continuously observing the rhythm. Notify the provider and prepare for possible escalation of care. For this patient with tumor lysis syndrome, TLS, is being monitored for complications, which finding indicates neuromuscular toxicity requiring immediate intervention. A. Flank pain. B. Muscle twitching. C. Oliguria. D. Tachycardia. Answer B. Muscle twitching. This is correct. A classic sign of hypocalcemia-induced neuromuscular irritability. In tumor lysis syndrome, hyperphosphatemia can lead to hypocalcemia due to calcium phosphate deposition. Hypocalcemia increases neuronal excitability, resulting in muscle twitching, paresthesias, tetany, and potentially laryngospasm or seizures. Muscle twitching is an early cue of neuromuscular toxicity that requires prompt calcium assessment and intervention. In the NGN framework, recognizing this specific cue allows the nurse to anticipate hypocalcemia and prevent progression to life-threatening complications. For the patient with severe hyperkalemia, case 6.8 milliequivalent/L receives IV insulin and dextrose per provider order. What is the nurse's priority action immediately after administration? A. Check urine output. B. Monitor blood glucose every 15 minutes for 1 hour. C. Administer Kexalate, sodium polystyrene sulfonate. D. Repeat serum potassium level in 6 hours. Answer B. Monitor blood glucose every 15 minutes for 1 hour. This is correct. Addresses the most immediate risk of hypoglycemia. Insulin drives potassium into cells, but also lowers blood glucose. Even when dextrose is co-administered, hypoglycemia can occur, particularly if the patient has low glycogen stores, renal impairment, or receives a high insulin dose. Hypoglycemia can develop rapidly and lead to seizures, altered mental status, or cardiac dysrhythmias. Frequent blood glucose monitoring, e.g., every 15 to 30 minutes for the first hour, allows the nurse to detect and treat hypoglycemia before it becomes severe. This aligns with the CGMM principle of recognizing the highest acuity risk and taking proactive, safety-focused action. Rasburicase is ordered for this patient with tumor lysis syndrome, TLS, and an elevated uric acid level. What is the critical pre-administration action the nurse must take? A. Premedicate with diphenhydramine. B. Draw uric acid level from a central line. C. Hold allopurinol. D. Verify blood type. Answer B. Draw uric acid level from a central line. This is correct. Ensures accurate baseline measurement before the drug degrades the sample. Rasburicase breaks down uric acid not only in the patient's body, but also in the blood collection tube after the sample is drawn. If blood is drawn after rasburicase administration, or if the sample is not handled properly, the result will be falsely low and cannot be used to assess the true degree of hyperuricemia or guide further dosing. The critical pre-administration action is to obtain a uric acid level before the first dose, using proper technique, chilled tube, placed on ice, rapid transport. Drawing from a central line is acceptable, but the emphasis is on timing. The level must be drawn prior to infusion. In the NGN framework, this represents recognizing a unique pharmacological safety cue and acting to prevent erroneous lab interpretation. This patient receiving rasburicase for tumor lysis syndrome develops wheezing during the infusion. What is the nurse's immediate action? A. Slow the infusion rate. B. Stop the infusion and administer epinephrine. C. Give IV hydrocortisone D. Elevate the head of the bed. Answer B. Stop the infusion and administer epinephrine. This is correct. Immediate action for anaphylaxis. Wheezing during an infusion is a hallmark of anaphylaxis. The priority is to stop further administration of the causative agent and administer epinephrine, the first-line treatment for anaphylaxis, to reverse bronchospasm, vasodilation, and airway edema. Delaying epinephrine increases mortality. This aligns with the CGMM principle of recognizing a high acuity cue, wheezing during drug infusion, and taking decisive, evidence-based action without delay. Additional safety note: rasburicase is contraindicated in glucose 6-phosphate dehydrogenase (G6PD) deficiency because it can cause severe hemolysis and methemoglobinemia. Screening for G6PD deficiency should be completed before administration. The occurrence of anaphylaxis, wheezing, is a separate, acute emergency requiring immediate intervention as outlined above. This patient with tumor lysis syndrome has a serum potassium level of 7.2 milliequivalent/L. The cardiac monitor suddenly displays a sine wave pattern. What is the nurse's next intervention? A. Administer IV furosemide B. Administer IV calcium gluconate C. Administer sodium bicarbonate D. Administer albuterol nebulizer. Answer B. Administer IV calcium gluconate. This is correct. Stabilizes the cardiac membrane in hyperkalemic emergencies. A sine wave pattern on ECG is a late, life-threatening manifestation of hyperkalemia, indicating severe conduction delay and imminent cardiac arrest. IV calcium gluconate, or calcium chloride, does not lower serum potassium, but rapidly stabilizes myocardial cell membranes, reducing the risk of ventricular fibrillation and asystole. This is the priority intervention to buy time for potassium-lowering therapies. In the NGN framework, recognizing the sine wave pattern as a high acuity cue for hyperkalemic cardiac instability leads to immediate, decisive action with calcium. This patient with tumor lysis syndrome, TLS, requires aggressive intravenous hydration to prevent acute kidney injury. Which fluid regimen is best for initial hydration? A. D5W at 200 milliliters per hour. B. 0.9% NaCl at 300 milliliters per hour. C. 3% NaCl at 100 milliliters per hour. D. Lactated ringers at 150 milliliters per hour. Answer B. 0.9% NaCl at 300 milliliters per hour. This is correct. Isotonic saline supports volume expansion, renal perfusion, and uric acid excretion. Normal saline, 0.9% NaCl, is the preferred initial fluid for TLS. It restores intravascular volume, corrects hypovolemia, and promotes a high urine flow rate to enhance excretion of uric acid, potassium, and phosphorus. The rate, typically 200 to 300 ml/HR or higher, is titrated to achieve urine output greater than 100 milliliters per hour. Isotonic saline avoids the additional potassium found in lactated ringers and provides chloride to support metabolic alkalosis if needed. In the NGN framework, this choice reflects understanding of the pathophysiology, preventing acute kidney injury through dilution and diuresis, and selecting the safest, most effective initial fluid. This patient with tumor lysis syndrome, TLS, has received 1 liter of 0.9% normal saline for aggressive hydration. Urine output remains absent, anuria. The most recent creatinine level is 3.9 milligrams per deciliter. What is the priority nursing action? A. Notify nephrology for emergent dialysis. B. Double the fluid infusion rate. C. Administer IV mannitol. D. Insert a Foley catheter. Answer A. Notify nephrology for emergent dialysis. This is correct. Anuria with worsening renal function indicates refractory TLS requiring renal replacement therapy. In TLS, aggressive isotonic hydration is the first-line measure to maintain urine output and excrete uric acid, potassium, and phosphorus. Failure to achieve urine output despite adequate fluid resuscitation, especially with a creatinine of 3.9 milligrams per deciliter, indicates established acute kidney injury that is unlikely to reverse with additional hydration alone. Emergent dialysis, or continuous renal replacement therapy, is indicated to correct severe electrolyte abnormalities, hyperkalemia, hyperphosphatemia, and remove uric acid. In the NGN framework, recognizing the cue of anuria after appropriate fluid challenge combined with elevated creatinine prompts the nurse to escalate care to nephrology without delay. This patient is diagnosed with active tumor lysis syndrome, TLS, and has a uric acid level of 14 milligrams per deciliter. Which medication is CONTRANDACTD as initial therapy? A. Furosemide. B. Allopurinol. C. Albuterol. D. Calcium gluconate. Answer B. Allopurinol. This is correct. Contraindicated as initial therapy for active TLS with existing hyperuricemia. Allopurinol is a xanthine oxidase inhibitor that prevents the formation of new uric acid. It does not lower already elevated uric acid levels and may take days to show effect. In active TLS where uric acid is already high, 14 milligrams per deciliter, allopurinol is ineffective for rapid uric acid reduction and can paradoxically increase xanthine levels, contributing to crystal nephropathy. The guideline preferred agent for acute, established TLS is rasburicase, which rapidly degrades existing uric acid. Allopurinol may be started after the acute phase for long-term prevention, but is contraindicated as the initial therapy in active TLS with hyperuricemia. A patient with tumor lysis syndrome, TLS, develops a generalized seizure. Laboratory results show a serum calcium level of 6.9 milligrams per deciliter. Which stat medication should the nurse anticipate administering? A. IV calcium gluconate. B. IV magnesium sulfate. C. IV potassium chloride. D. PO phosphate binders. Answer A. IV calcium gluconate. This is correct. Rapidly corrects hypocalcemia to stop seizure activity. In TLS, hyperphosphatemia leads to precipitation of calcium phosphate, causing symptomatic hypocalcemia. A serum calcium of 6.9 milligrams per deciliter is critically low. Hypocalcemia increases neuronal excitability and can cause seizures, tetany, laryngospasm, and prolonged QT with cardiac dysrhythmias. IV calcium gluconate, or calcium chloride, rapidly raises serum ionized calcium, stabilizing neuronal membranes and terminating seizure activity. This aligns with the CGMM principle of recognizing the electrolyte, seizure link, and taking immediate corrective action. This patient is scheduled to receive rasburicase for tumor lysis syndrome. Which teaching point is most important for the nurse to communicate to the healthcare team regarding safe administration? A. Infuse over 2 hours. B. No blood draws from peripheral lines after infusion. C. Take with food. D. Monitor for green urine. Answer B. No blood draws from peripheral lines after infusion. This is correct. Prevents falsely low uric acid levels that could mask disease severity. Rasburicase continues to degrade uric acid in blood samples after they are drawn. If blood is obtained from any site, peripheral or central, after the infusion has started, the uric acid result will be artificially low, potentially leading to undertreatment. While the statement specifies peripheral lines, the critical principle is that all uric acid levels must be drawn before the first dose, using proper handling, chilled tube, placed on ice, rapid transport. Post-infusion levels cannot be interpreted reliably. Additionally, screening for G6PD deficiency must occur before administration to prevent hemolysis and methemoglobinemia. This teaching point reflects the highest priority safety consideration for the interprofessional team. For a patient is at risk for tumor lysis syndrome, TLS, after initiating chemotherapy, which dietary instruction should the nurse include to help prevent TLS complications? A. Increase bananas and spinach. B. Restrict dairy and nuts. C. Drink orange juice daily. D. Add salt to all meals. Answer B. Restrict dairy and nuts. This is correct. Reduces phosphorus intake to prevent hyperphosphatemia and secondary hypocalcemia. TLS causes release of intracellular phosphorus, leading to hyperphosphatemia. High phosphate foods such as dairy products, nuts, beans, and organ meats can exacerbate this condition. Hyperphosphatemia can precipitate calcium phosphate crystals in the kidneys, worsening acute kidney injury, and can cause symptomatic hypocalcemia, e.g., seizures, tetany. Dietary phosphate restriction is a key preventive measure during the high-risk period. In the NGN framework, this teaching reflects understanding of the pathophysiology of TLS and the role of nutrition in preventing complications. For this patient with tumor lysis syndrome, TLS is being monitored for complications. Which finding indicates the need for emergent dialysis? A. Uric acid 10 mg per deciliter. B. Potassium K 5.2 milliequivalent/LC. Potassium K 7.0 milliequivalent/L with anuria. D. Calcium Cis superscript 2 8.0 mg per deciliter. Answer C. Potassium K 7.0 milliequivalent/L with anuria. This is correct. Combination of severe hyperkalemia and renal failure requires emergent dialysis. A potassium level of 7.0 milliequivalent/L is life-threatening, especially when accompanied by anuria, absence of urine output. Anuria indicates that the kidneys are no longer able to excrete potassium, and medical interventions, insulin/glucose, albuterol, Kxalate, will be insufficient or transient. Dialysis, or continuous renal replacement therapy, is indicated to rapidly remove potassium, correct acidosis, and manage volume status. In the NGN framework, this combination of cues, severe hyperkalemia plus renal failure, represents a critical threshold where the nurse must recognize that medical management has failed and dialysis is the definitive intervention. A patient with tumor lysis syndrome, TLS, has completed initial treatment, including rasburicase and aggressive hydration. A post-treatment uric acid level drops to 2 mg per deciliter. What is the nurse's next action? A. Stop all monitoring. B. Continue ECG monitoring. C. Discharge home. D. Administer IV iron. Answer B. Continue ECG monitoring. This is correct. Essential to detect life-threatening electrolyte shifts that occur after initial treatment. In TLS, the risk of severe electrolyte disturbances, hyperkalemia, hypocalcemia, persists for 12 to 72 hours after chemotherapy due to continued cell lysis. ECG monitoring is critical to identify early signs of hyperkalemia, peak T waves, widened QRS, and hypocalcemia, QT prolongation, before they progress to cardiac arrest. Even with a normalized uric acid, the patient remains in a high acuity window requiring vigilant monitoring. In the NGN framework, this reflects the nurse's understanding that normalization of one lab value does not equate to overall stability. Ongoing surveillance is essential. For this patient who experienced tumor lysis syndrome, TLS, during chemotherapy is being prepared for discharge. Which discharge teaching priority should the nurse emphasize to help the patient recognize early signs of relapse? A. Restart allopurinol at home. B. Report muscle cramps or palpitations. C. Limit fluids to 1 liter per day. D. Take calcium supplements. Answer B. Report muscle cramps or palpitations. This is correct. Directly addresses early warning signs of recurrent TLS. Muscle cramps, including tetany, facial twitching, can indicate hypocalcemia, while palpitations may signal hyperkalemia or other electrolyte disturbances. These subtle symptoms can precede severe complications such as seizures, cardiac dysrhythmias, or acute kidney injury. Teaching the patient to recognize and promptly report these cues enables early intervention before the condition progresses. In the NGN framework, this empowers the patient to be an active partner in recognizing relapse, aligning with safe transition of care. For a patient is scheduled to begin chemotherapy for a newly diagnosed malignancy, which cancer type carries the highest risk for tumor lysis syndrome, TLS, and requires the most aggressive prophylactic measures? A. Chronic lymphocytic leukemia. B. Burkitt lymphoma. C. Early stage breast cancer. D. Prostate cancer. Answer B. Burkitt lymphoma, this is correct, carries the highest TLS risk, often exceeding 90% without aggressive prophylaxis. Burkitt lymphoma is a highly aggressive B-cell non-Hodgkin lymphoma with an extremely rapid cell turnover rate. The massive tumor burden and exquisite sensitivity to chemotherapy result in widespread cell lysis immediately after treatment initiation. The TLS risk is so high that prophylaxis, aggressive hydration, rasburicase, ECG monitoring, frequent electrolyte checks must be started before the first dose of chemotherapy. In the NGN framework, recognizing this as a TLS time bomb allows the nurse to anticipate and prepare for life-threatening electrolyte disturbances before they occur. A nursing instructor is teaching a group of students about the pathophysiology of tumor lysis syndrome, TLS. Which statement best explains the underlying mechanism of TLS? A. Chemotherapy destroys the kidneys, leading to electrolyte imbalances. B. Cancer cells burst, flooding the bloodstream with potassium and uric acid. C. Radiation therapy causes dehydration, concentrating electrolytes in the blood. D. Immunotherapy blocks the kidneys from excreting electrolytes. Answer B. Cancer cells burst, flooding the bloodstream with potassium and uric acid. This is correct. Accurately describes the core pathophysiology of TLS. In TLS, rapid tumor cell lysis, often triggered by chemotherapy in highly sensitive tumors, releases large amounts of intracellular contents, including potassium, phosphate, and nucleic acids, which metabolize to uric acid, into the bloodstream. This sudden release overwhelms the body's homeostatic mechanisms, leading to hyperkalemia, hyperphosphatemia, secondary hypocalcemia, and hyperuricemia, with consequent risks of cardiac arrhythmias and acute kidney injury. This statement reflects a clear, concise understanding essential for nursing care. For this patient with tumor lysis syndrome, TLS, is receiving aggressive hydration and rasburicase, which laboratory value is most critical to monitor every 6 hours during the acute phase. A. Hemoglobin B, potassium C, albumin D, platelets. Answer B. Potassium. This is correct. The most critical electrolyte to monitor frequently in TLS. TLS causes rapid release of intracellular potassium from lysed tumor cells, leading to hyperkalemia, the most immediately life-threatening complication. Hyperkalemia can progress quickly and cause cardiac arrhythmias, peak T waves, widened QRS, and cardiac arrest. Frequent monitoring every 4 to 6 hours allows early detection and intervention, calcium gluconate, insulin/glucose, albuterol, or dialysis. In the NGN framework, recognizing potassium as the highest acuity monitoring parameter enables the nurse to anticipate and prevent lethal dysrhythmias. For a patient about to receive rasburicase for tumor lysis syndrome, TLS, asks about possible side effects. What is the nurse's best response? A. It causes kidney stones. B. You may develop blue discoloration of the skin. C. It increases bleeding risk. D. It tastes metallic. Answer B. You may develop blue discoloration of the skin. This is correct. Accurately describes a serious potential side effect. Rasburicase can cause methemoglobinemia, particularly in patients with G6PD deficiency, leading to oxidation of hemoglobin and impaired oxygen delivery. This results in cyanosis, blue discoloration of the skin, lips, and nail beds, despite normal pulse oximetry readings. Methemoglobinemia is a medical emergency that can cause tissue hypoxia, organ failure, and death if untreated. The patient should be instructed to report any blue discoloration, shortness of breath, or fatigue immediately. This response provides critical safety information and empowers the patient to seek prompt care. For this patient with tumor lysis syndrome, TLS, is receiving aggressive hydration and rasburicase, which finding indicates that treatment is currently effective and the patient is stabilizing. A. Uric acid 12 mg per deciliter. B. Urine output 80 milliliters per hour with normal ECG. Calcium, Ca superscript 2, 7.0 milligrams per deciliter. D. White blood cell, WBC, count 80,000/L. Answer B. Urine output 80 milliliters per hour with normal ECG. This is correct. Demonstrates adequate renal perfusion and absence of hyperkalemic cardiac toxicity. Maintaining urine output greater than or equal to 80 100 ml/HR is a key goal of aggressive hydration in TLS, as it promotes excretion of uric acid, potassium, and phosphate, reducing the risk of acute kidney injury. A normal ECG rules out significant hyperkalemia, peak T waves, widened QRS, and hypocalcemia, QT prolongation, which are the most life-threatening complications. Together, these findings indicate that the patient's renal function is protected and electrolyte disturbances are under control, key indicators of effective management. Critical safety alerts for TLS. Risk. Action. K greater than 6.0 plus ECG changes. Calcium gluconate IV stat. Anuria. Dialysis consult now. G6PD deficiency. Rasburicase contraindicated. Twitching/seizures. IV calcium gluconate. TLS emergency treatment mnemonic. Lysis kills. Labs Q4-6H. K/UA/PO4/C superscript 2/CR. Yield to cardiac monitoring. Peak T waves equals emergency. Saline hydration. NS 300 milliliters per hour. Insulin/glucose for K greater than 6.0. Seizure precautions. Hypocalcemia. K control first. Deadliest abnormality. IV calcium gluconate for arrhythmias/tetany. Limit POK/PO4 diet teaching. Lasix only after euvolemia. Start rasburicase stat, not allopurinol. Burkitt lymphoma, the TLS time bomb. Why Burkitt lymphoma is the highest risk malignancy for tumor lysis syndrome, TLS. Extremely rapid cell turnover. Burkitt lymphoma is one of the fastest growing human tumors, with a doubling time of only 24 to 48 hours. This leads to a massive tumor burden in a short period. Large intracellular contents. Because of the high number of rapidly dividing cells, there is an enormous total amount of potassium, phosphate, and nucleic acids, which break down into uric acid, inside the lymphoma cells. High sensitivity to chemotherapy. Burkitt lymphoma cells are exquisitely sensitive to chemotherapy. When treatment begins, they lyse, break open, almost immediately, releasing all those intracellular contents into the bloodstream in a massive burst. Consequences of the burst. Potassium hyperkalemia, life-threatening cardiac arrhythmias. Phosphate hyperphosphatemia combines with calcium to form calcium phosphate crystals that deposit in the kidneys, worsening acute kidney injury. Nucleic acids converted to uric acid crystals can obstruct renal tubules, acute kidney injury. Spontaneous TLS. Some patients already have laboratory signs of TLS before any treatment due to the tumor's rapid growth outpacing the body's clearance mechanisms. Prophylaxis is critical. Because the risk of TLS is greater than 90% without intervention, aggressive preventive measures must be started before the first dose of chemotherapy. This includes aggressive forehydration with isotonic fluids, rasburicase to rapidly lower uric acid, frequent electrolyte monitoring, continuous cardiac monitoring, avoiding potassium-containing fluids. Remember, Burkitt equals break cells burst electrolytes. Even with prophylaxis, TLS may still occur. Close monitoring is essential during the first 24 to 72 hours after chemotherapy initiation.